Hello viewers, welcome back to yet another episode of Anatomy Weekly. Since our last episodes, we have been talking about the development of joints. If we look at our skeletal framework, we know that there are movements possible which vary according to the needs at different joints. So today, we'll proceed one step further and talk about the classification of joints. Now these joints can be classified functionally, that is, as per their possible movements into three different types. A joint which is immobile is called synarthrosis. A joint which is partially mobile is termed amphiarthrosis. And a joint which is freely movable is termed a diarthrosis. Again, if we look at the structure, the joints can be classified according to the intervening tissues into three different types. Number one is a fibrous joint, number two, a cartilaginous joint, or number three, synovial joints. Now these two classifications can be correlated, as synarthrosis, which are immovable joints, are mostly fibrous, amphiarthrosis, which are partially movable joints, are mostly cartilaginous, whereas diarthrosis, which are freely movable joints, are synovial.
Let us first talk about the fibrous joint. Now, the intervening tissue in the fibrous joint is the fibrous connective tissue, which consists primarily of the collagen fibers, and there is no joint cavity present in the fibrous joint. Now, these joints are usually immobile and thus known as synarthrosis, which we have already discussed. The three most definable types of fibrous articulation are sutures, Gom Forces, and syndesmosis. Starting with sutures. Now, sutures are immobile joints in the cranium, that is, the cranial bones, which are plate-like bones of the skull, are slightly mobile at birth because of the connective tissue present in between them, which are termed as fontanelles. This initial flexibility of these bones allow the infant's head to get through the birth canal at delivery and permits the enlargement of brain after birth. The growth of the skull bones has been discussed in our previous video. If you want to have a look, we have provided the link. You can go back and look at our previous video. If you look at a suture, the two bones are separated by a layer of membrane-derived connective tissue. The sutural aspect of each of these bones is covered by a layer of capsular lamella, which consists of the fibrous tissue, and this capsular lamella is continuous with the periosteum on both the endo and ectocranial surfaces. Now, beneath this layer, there is another layer which contains the osteogenic cells, and this layer is called the cambial layer. The area between the capsular layer consists of loose fibrous connective tissue. With age, these osteogenic surfaces become opposed, and on completion of growth, cranial sutures ossify, that is, the two adjacent plates fuse to form one bone, and this fusion is termed as synostosis. The synostosis occurs normally as the skull ages. It can begin in early 20s and continues into advanced age. As the skull enlarges, the fontanelle is reduced to a narrow layer of fibrous connective tissue. Next, coming back to the second type of fibrous joint, that is the Gom Forces. A Gom Forces is a peg and socket junction between a tooth and its socket, where the two components are maintained in intimate contact by the collagen of periodontium, connecting the dental cement to the alveolar bone. Syndesmosis are slightly movable joints. In syndesmosis, two bones are held together by an interosseous membrane consisting of collagen fibers. The syndesmosis maintains the integrity between long bones, and it resists forces that attempt to separate the two bones. For example, the tibia connects to the fibula, forming the middle and the inferior tibiofibular joint. The tibiofibular syndesmosis primarily provides strength and stability to the leg and ankle during weight bearing. The syndesmosis between the ulna and the radius, forming the middle radio-ulnar joint, permits rotation of the radius bone during forearm movement.
Moving on, let's talk about cartilaginous joints. In cartilaginous joints, the bones are attached to each other by hyaline cartilage or by fibrocartilage. Now, these joints tend to be less rigid than the fibrous articulations. If you recall, these slightly movable joints are classified as amphiarthrosis. Depending on the type of cartilage involved, the joints can be further classified into two types: primary cartilaginous joints and secondary cartilaginous joints. The primary cartilaginous joints, or synchondroses, occur where the advancing centers of ossification are separated by an area of hyaline cartilage. These are present in all long bones which form from more than one center of ossification. These are temporary and are always concerned with growth. The synchondroses joints are almost exclusively associated with the growth plates. The synchondroses as a mode of bone growth has already been explained in our previous videos. Kindly go through them. We have provided the link above. Since the hyaline cartilage retains the capability to ossify with age, the synchondrosis tends to synostose when growth is complete. That means the cartilage will be replaced by bone. The secondary cartilaginous joints, or symphysis, occurs in the midline. In the mandible, it is present as the symphysis manti. In the sternum, it is present at the manubriosternal joint. It is present as the pubic symphysis of the hip bone, and in the vertebral column, we can find symphysis as the intervertebral discs. All except the mandibular symphysis, that is the symphysis manti, occur in the postcranial skeleton and they resist synostosis, which means these cartilages persist and they are never converted into bones. The symphyses are largely defined by the presence of an intervening pad or disc of fibrocartilage, which is interposed between the articular hyaline cartilage that covers the ends of the two bones that form the joint. The intervening pad or disc varies in width, and the whole region is generally bound by strong, tightly adherent, dense connective tissue. Collagenous ligaments extend from the periosteum of the articulating bones across the symphysis and blends with the hyaline and fibrocartilaginous parts of the joint.
Coming to the synovial joints, the synovial articulations are different from both the fibrous and the cartilaginous joints. Although in a synovial joint, the bones involved are linked by a fibrous capsule, the articulating bony surfaces are generally separated from each other by presence of the joint cavity. The articular surfaces are mostly formed by a specialization of the hyaline cartilage, which reflects their pre-formation as parts of cartilaginous models in embryonic life. However, the articular surface of the sternoclavicular joint, the acromioclavicular joint, and both temporomandibular surfaces are covered by dense fibrocartilage. The articular cartilage provides a lubricated surface ideal for easy movements. The hyaline cartilage is also able to resist and distribute large forces of compression and shear generated by movement, body weight transfer, and muscle contractions. They have no blood supply, thus their nutrition and maintenance largely depend on diffusion from a peripheral vascular plexus of the synovial membrane. A fibrous capsule completely encloses a joint except where it is interrupted by synovial protrusions. It is composed of interlacing bundles of parallel fibers of white collagen and is attached continuously around the ends of the articulating bones. The fibrous capsule is perforated by vessels and nerves supplying the joint, and it may usually exhibit local thickenings of collagen fibers, which are called the capsular ligaments. Some part of the capsules are reinforced or replaced by tendons of the nearby muscular expansions called the accessory ligaments. The synovial membrane lines these fibrous capsules and covers exposed osseous surfaces, intracapsular ligaments, bursa, and tendon sheaths. However, it does not cover the articular cartilages. The synovial membrane secretes the synovial fluid that lubricates the movement between the articulating surfaces. The synovial fluid occupies the joint, the bursa, the tendon sheaths, and it provides nutrition to the joint structure from the peripheral vascular plexus present in it. The capsule sometimes may contain apertures through which the synovial membrane protrudes out, creating a bursa.
Adipose tissue or articular fat pads occur in the synovial membrane in many joints. These pads, folds, and fringes are flexible, elastic, and deformable cushions that fill up the potential spaces and irregularities in the joints. During the movement of the joint, they help to accommodate the changing shape and volume of the irregularities. A meniscus occurs between the articular surfaces where congruity is low. It consists of fibrocartilage and is not covered by synovial membrane. The term meniscus is usually reserved for incomplete discs, for example, those found in the knee joint and occasionally found in the acromioclavicular joints. On the other hand, an articular disc like that present in the temporomandibular joint is usually complete, similar to menisci, and it consists of fibrocartilage. The articular cartilage of the temporomandibular joint divides the joint space structurally into two synovial cavities. They often have small perforations. In other joints like the sternoclavicular and the inferior radioulnar joints, this disc may be complete or incomplete. A labrum is a fibrocartilaginous annular lip attached to an articular margin. For example, in this diagram you can see how the glenoid labrum is attached to the outer margin of the glenoid cavity. It deepens the socket and increases the area of contact between the articular surfaces, and it may act as a lubricant spreader. The capsule of these joints overlap and covers the fibers of the labrum. These joints receive its vascular supply from the periarticular arterial plexuses, whose branches pierce the fibrous capsule and form subsynovial vascular plexuses. A joint is innervated by articular branches of the nerves that supply the muscle acting on the joint and that also supply the skin overlying the same joint. This is called Hilton's law.
Now we know the structure of a typical synovial joint. So let us see how the synovial joints can be classified. The synovial joints may be classified according to their shape into plane joints, a hinge joint, pivot joints, bicondylar joints, ellipsoid joints, saddle joints, and ball and socket joint. The plane joint are appositions of flat bony surfaces like the intermetatarsal and some intercarpal joints. Now the movements possible in a plane joints are pure translational or sliding movements between the adjacent bones. A hinge joint resembles a hinge because movement here is largely restricted to only one plane, which means that they are uniaxial. Example for the hinge joints which you can see over here is the humero-ulnar joint. Pivot joints are uniaxial joints in which an osseous pivot in an osteoligamentous ring allows rotation only around the axis of the pivot. Pivot may rotate in rings, like for example here you can see the head of the radius is rotating with the annular ligament and ulnar radial notch. Other examples of pivot joint is the atlantoaxial joint. The bicondylar joint like the knee joint which you can see over here are predominantly uniaxial with primary movement in one plane but with limited rotation around the second plane. The bicondylar joint are so named because they are formed of two convex condyles which articulate with concave or flat surfaces like which we are seeing over here in the knee joint. Ellipsoid joints are biaxial and consist of an oval convex surface opposed to an elliptical concavity. Like the metacarpophalangeal joint, again which you can see over here. Now the movements possible in the ellipsoid joint can be flexion, extension, abduction and adduction. Saddle joints like this calcaneo-cuboid joint are biaxial with primary movements occurring in two planes. They have surfaces which are concavo-convex. Now each of these surfaces is maximally convex in a particular direction and is maximally concave at right angles to the earlier direction. The convexity of the larger surface is opposed to the concavity of the smaller surface and vice versa. Lastly, the ball and socket joint, like the shoulder joint which you can see over here, are multiaxial and are formed by the reception of a globoid head into an opposing cup. Their surfaces, although resembles part of spheres, are not very strictly spherical but slightly ovoid, where the congruence is not perfect in most positions and indeed it occurs only in one position. The other common example for the ball and socket joint is the hip joint.
Now that you know about the synovial joints, let's talk about another type of classification. According to this, the joints are classified as simple, compound and complex joints. A synovial joint in which two bones meet in a single joint cavity is called a simple joint. In a compound joint, more than two bones will meet in a single joint cavity. If the joint cavity is divided completely or partially into two compartments by meniscus or articular disc, we call that joint a complex joint. So that's all about the classification of joints. Keep watching Anatomy Weekly to learn more about the amazing anatomy of the human body. We'll see you next time. Thank you.